enzyme will be high because it's affecting the liver, okay? It's a sensitive indicator of alcohol use when they're running, folks, okay? So the only treatment you could do is support him when somebody is already alcohol, intoxicated. You cannot do anything, right? So that's alcohol intoxication. Now, if you look at the withdrawal, it is so important to understand how it happened in order. So the first symptom of withdrawal is tremor, insomnia, they sweat all over, agitation, and GI upset. That starts about 3 hours from their last drink. That's the first one. Let me write that. So these people, within 3 hours, they will start having the shakiness and all these symptoms, folks. Then possibly after 12 hours, they could get withdrawal seizure. Okay, they could get withdrawal seizure, and then followed by alcohol hallucinations, right? So they have visual. You should know that it's usually visual hallucination. That's what they have. All the NBMEs that I have seen, they only ask you this: delirium tremens, okay? Now, delirium tremens, it's very specific to start after 48 hours from the last drink, so which means 2 days. That's delirium tremens. Now, the question usually say, this patient is hospitalized for something else. So the patient come to the hospital for something else, or for surgery or anything. Remember, if you are in hospital, you don't get the access to alcohol, isn't it, folks? So that's why that 48 hours is usually hospitalized patients, what we call delirium tremens. Now, to learn more about delirium tremens, we go to the previous page. It's right there. What is delirium tremens? Let's go there. So delirium tremens, look at that, occurs 2 to 4 days after the last drink. Classically seen in hospital setting when inpatient cannot drink. That's what we just said, isn't it, folks? So most of the question itself has started with hospitalized patients, because if they're outside, they will find a way to get the alcohol. Okay. Now, what is delirium tremens? What are the symptoms? Altered mental status, hallucination, autonomic hyperactivity, anxiety, seizure, tremor, psychomotor agitation, insomnia, and nausea. All these are considered symptoms, folks. Okay, these are important symptoms. You should be able to read and pick up what is delirium tremens. Of course, a good indicator, they will tell that it's 48 hours from the last drink. The timing has to be there, but still you could see that, okay? Now, when people have delirium tremens, long-acting benzodiazepine is the way to calm them down. It reduces their anxiety, basically, right? So we'll talk about that on the form, but that's delirium tremens. This is considered high yield, okay? Very important. Now, let's go back here. I will put here 593 page. Every time you study this section, you go to the previous page and refer the delirium tremens. What is delirium tremens? Are we clear with that, folks? So we know the symptom of intoxication and we know the symptoms for withdrawal, folks, okay? Now, next. The next high yield for step one is opioids. Pain medication. Opioids are pain medication, okay? Now, and heroin, by the way. It gives you pupillary constriction, decreased GI motility, which makes sense. When you take too much pain medication, it gives you constipation, isn't it, folks? We talked about this, right? Okay. Respiratory and CNS depression. See, why? Opioids reduces the respiratory rate. Where does it work? In medulla oblongata of the brainstem. It goes and inhibits it, right? So you should know that it works in medulla oblongata. Euphoria, decreased gag reflex, seizures. Look at the line. Most common cause of drug overdose, death. A lot of people take it. They found dead in their bed because it blocks the respiration. Course, that's the idea. If you catch them at the right time, you could give naloxone. That's an antidote for overdose treatment. So that's opioid intoxication. Let's take a look at what happened when they're in withdrawal. See, if you know this symptom, you're going to go opposite. Here it's a pupillary constriction, meiosis, but here it's going to be dilated pupil. That's mydriasis. Is that clear, folks? So opposite, okay? And diarrhea, flu-like symptom. This is what I tell. If you see a patient who has all the flu symptoms, but it's not a flu season, most likely that's an opioid withdrawal. Okay, flu comes in certain months of the year. So these people will have everything what a flu patient would have. Look at this, folks. Rhinorrhea, yawning, nausea, stomach cramps, sweating, pylori reaction, what we call colic, lacrimation, watery eye, everything, okay? So that's a flu-like symptoms. So that's a withdrawal. What do we treat? We give methadone. Methadone is a long-acting opioid itself. So you could ask me, why do we give a pain medication to somebody who's addicted to that? Well, we are giving a long-acting, which will help them to slowly come out of it. Is that clear, folks? We'll talk about that with the treatment. There's so much. There's about 3 medications you have to give, but methadone is one of the long-acting for rehab. So that's opioids, folks, okay? Is everybody clear? All right. Now, after opioids, amphetamines, folks, methadone. Now, this medication, this substance gives you euphoria, grandiosity, pupillary dilation, prolonged wakefulness, hyperalertness. That's your Adderall, isn't it, folks? It does all these things, right? Alertness, hypertension. When you look at all these symptoms, doesn't it look like it's a sympathetic symptoms? So what does this amphetamines do? Increase norepinephrine, norepi in the cleft of the nerve junction between the junctions, folks, okay? The increase norepinephrine, that's all it does, folks. We studied that, okay? So if you increase norepinephrine, that means more sympathetic function. So you have hypertension, alpha-1 agonist. Is that clear, folks? They would also work in the heart, don't you think so? So if they work in the heart, what happened? They could even give you cardiac arrest. This is why when ADHD people, sometimes they take a little bit more Adderall because it's not working. What is one complaint they have? Their chest hurts, because as you increase the dosage, it will also increase beta-1 agonist activity. Is everybody clear, folks? So they could even come to not necessarily cardiac arrest, but some chest pain, folks, okay? So they have that fractured teeth and all these things, okay? Now, treatment, benzodiazepine for agitation and seizure. That's all it is. So that's amphetamines, folks. And you could literally tell cocaine intoxication will be the same thing. Why? What does cocaine do? Increase norepinephrine in the cleft. Is that clear, folks? That's exactly the same. Let's take a look at cocaine. The only difference for cocaine, it also gives you impaired judgment. That's the only thing. Okay, it gives you impaired judgment, but other than that, all the symptoms are same. Look at this: sudden cardiac death, angina, chest pain, all those things. Chronic use may lead to perforated nasal septum due to the vasoconstriction effect. Because people sniff cocaine, don't think it destroys the nasal septum. It's not that. When they sniff, those cocaine works on the blood vessel that supplies the nasal septum. Okay. So then when they work on the blood vessel, what is going to happen? Vasoconstriction. When they have a vasoconstriction, less blood perfusion, less oxygen, they go through ischemia and infarction and necrosis. Is that clear, folks? It is not a direct effect of cocaine. It's an indirect effect of vasoconstriction. So you should know that cocaine will go to the blood vessel that supplies the septum, will cause ischemia, infarction, all those steps. So everybody clear, folks? Okay, so that's that. Now, when people come with cocaine, right, they come with a chest pain because it's working on the heart now. The first thing that we do, we never give beta blocker. You see, it says controversial. No beta blocker. I'll explain why. Why you don't give beta blocker? If you give beta blocker, all the beta receptors are blocked, so you are protecting the heart. But now all the norepinephrine is going to go to the blood vessel. and bind to alpha-1 receptors, and they will have a hypertensive crisis, folks, okay? Where did we study similar concept? We don't give beta blocker first, and we give alpha blocker first. Pheochromocytoma, remember that, folks? It's the same thing here. So before you protect the heart, you need to protect the blood vessel, because blood vessels are very weak structure. Heart is a strong structure, okay? So we need to protect the heart first, folks, okay? That's the idea. Now, that's cocaine, right? Now, cocaine and amphetamines are pretty much the same, except one has impaired judgment. Everybody clear, folks? Okay. Now, since we talked about cocaine intoxication, look at the withdrawal, folks. It's restlessness, hunger, severe depression, and deep disturbances. They are literally cannot do anything, folks. Okay, so that's cocaine. Just to take a look at caffeine. When people drink a lot of caffeine, the first thing they tell is palpitation, isn't it? Because why? Caffeine. What is caffeine? Caffeine is adenosine antagonist. It's adenosine antagonist, right? It blocks the adenosine receptors in the brain. When they block that, that's the one that gives you alertness, that wakes you up. So that's good in the brain, but not in the heart. Is that clear, folks? Okay. Agitation, tremor, insomnia, right? They say that if you drink a very strong coffee, it's hard to fall asleep. So those are all intoxication. And this is a withdrawal symptoms. Headache, difficulty concentrating, flu-like symptoms. So those are all withdrawal symptoms, folks, okay? So that's for caffeine. Let's continue. Now, nicotine, just to talk about that. Nicotine doesn't really have intoxication, even though it says restlessness. More of is a withdrawal problem. Is that clear, folks? It's a withdrawal problem, okay? When they have that withdrawal, irritability, anxiety, restlessness, and decreased concentration. Decreased concentration, increased appetite and weight and stuff, folks. Treatment is, what do? You give them nicotine patch, gum, or different medication. Highlight bupropion. It's a famous medication to help people quit smoking, folks, okay? Now, when it comes to quit smoking, always remember, nobody becomes successful in one time. It has to be like 3-4 attempts, and then finally, actually, the statistic shows only at the 7th time, usually they quit. So they have to try 7 times to quit, which takes years to do that, okay? So that's the idea. So that's nicotine, folks. Let's go here. In this topic, recently, you need to know these and this for sure. Okay, let's start with PCP, right?
Dr. Roy, can I ask a quick question? Some people don't get as addicted to certain substances as other people, like smoking. I've heard stories, very unusual, of course, but I've heard stories of people who just were able to quit smoking so easily. I know it's not common. And then same like with caffeine. My mom and her sister, they're addicted to caffeine. If they don't have their morning coffee, they get terrible headaches. I can drink coffee every day for years, miss the coffee, and never get withdrawal symptoms. What makes the difference between why some people get addicted to certain substances and others don't?
It's your genetics and your body, how your liver enzymes react. Right? So it's a liver and also brain. As you're right, different people have different threshold. Okay. It's like asking, some people get drunk with 2 drinks. Some people can have 6 drinks, right? It's about how their body handles it.
Okay, like processes it.
It's a process, and also it's individual organ, right? So if you see, it all go back to the genetics. Your chromosome is what determines each of your organs to functions and what you are carrying, right? So it's a genetics plus it's each individual body. So in another word, there is no proper explanation somebody can tell why these people get addicted to this and that people not. It's basically their body.
Okay.
Right?
Okay. Thank you.
And also, if there's something called conditioning, right? So let's say if I make you drink coffee every day, and then I keep talking about coffee to you all the time, and you drink coffee every day for like 3 months, and all of a sudden you don't drink it, you will get the effect of it. It's because it's playing psychology, because of the conditioning. We always talk about coffee to you, and now all of a sudden we are not drinking. Then your brain, that's where the classical conditioning comes. So you are not getting addicted to coffee is because basically when you drink coffee, I don't think you care what you drink. As soon as anything hot, probably you will drink.
Yeah, that's pretty true.
There you go. So it's all about what you tell the people, right? So it's a conditioning part of the process of that.
Thank you.
All right. So that's that. Next, PCP. When it comes to PCP, it comes on the exam. This person is going to a bar and getting into a fight and all these things. They become violence, folks. Okay, that's important. And agitation. And they get this impulse, makes them very angry. And psychomotor agitations, meiosis, tachycardia, hypertension, but most important is violence and agitation, folks. Okay, they always get into fight and stuff. So that's PCP. Now, when it comes to LSD, here mostly it's flashbacks. That's one of the buzzwords they could tell. This used to be a very famous topic, but they go down a little bit now, and they started asking PCP now. So, it's like a seasonal. They were focusing on one substance, now they are focusing on the other one. So PCP. And another one is cannabinoids, that's almost pretty much normal in most of the states now. So, but still you should know a little bit. They still have impaired judgment, folks. Okay, they still have impaired judgment. And the next one is perception of slow time. Those people, when they're high, they talk so slow, isn't it? Is it because they see everything slowly? Okay, now that's why we tell them they cannot drive even though they have legal prescription. Why? Because when they drive, they will see a car opposite is coming slowly, but it's not actually coming slowly. Okay, so their judgment, that's very important, folks. Okay, so those are that. Now, here, ecstasy, right? Everybody remember the Hangover movie? This is the substance that guy gives it, right? Mix and give it. So when you see ecstasy, I think the only thing that it should come to your mind, hyperthermia. Ecstasy gives you hyperthermia, folks, okay? It's a euphoric hallucination substance. Okay, increased thirst, bruxism, and disordered sensory and time perception and stuff. Life-threatening side effect is basically hyperthermia and hyponatremia. So that's something to keep in mind. So that's that, folks, okay? Now, I would suggest these are the key in hallucinogens to pay attention to, folks, okay? I think most likely you will have a question in PCP, like as I see all the NBMEs, all right? Now, let's go to alcohol use disorder, okay? Now, when it comes to alcohol use disorder, diagnosed using criteria for substance use disorder, the main complication is thiamine deficiency, okay? Because the more alcohol people drink, the more thiamine deficiency it becomes. It can become alcoholic cirrhosis, hepatitis, pancreatitis, peripheral neuropathy, testicular atrophy. All these things are effect or complication of alcoholic use, folks. Now, treatments to reduce the craving, you could take the naltrexone or some compressed disulfiram-like effect. You see, disulfiram effect gives you pain. When you take that medication and you drink alcohol, you get all those hangover symptoms and stuff. Support group, the AA group, what they call Alcoholics Anonymous, is helpful in sustaining all these things. Okay. Now, when it comes to alcohol use, the most important to know is Wernicke-Korsakoff. Okay, Wernicke-Korsakoff. These are two words together. Both of them gives you enough symptom, but I'm going to write something here. Wernicke is reversible. Korsakoff, it's not. It's irreversible. So each of them has symptoms. Okay, Wernicke has certain symptoms, which is reversible. Korasakov have certain symptoms which is irreversible. We're going to have to learn. This is considered a high-yield topic, folks, because they link this to neurology, okay? Now let's take a look here. It comes off of thiamine deficiency. Symptom can be precipitated by administering dextrose before vitamin B1. In biochemistry, we studied what is the biggest problem with thiamine deficiency. Pyruvate is backing up, all the pyruvate is going to lactic acid. Is that clear, folks? Why pyruvate is backing up? Because alcohol destroys thiamine. Without thiamine, PDH cannot function. Are we clear, folks? Now, imagine for those people, if you give more sugar, what happens? You are making more pyruvate, and more pyruvate is going to more lactic acid. You are not fixing the problem. That's why you have to give thiamine first and then dextrose after a while, folks. You have to give a couple of minutes, like, usually 15 to 20 minutes gap, okay? Now, there's a triad of confusion, ophthalmoplegia, and ataxia. All these three symptoms, confusion, ophthalmoplegia, ataxia, those are all Wernicke's. So that means when patient has confusion, ophthalmoplegia, and ataxia, they all will come back once you treat. So everybody clear, folks? All those symptoms will go away. But these three symptoms, or two most importantly, I'm going to highlight: memory loss and confabulation. Memory loss and confabulations are permanent. It says irreversible. If you have Korasakov, you lose your memory, and you also have confabulation. What is confabulation? Confabulation is a symptom. Basically, they are lying, but they don't even know that they are lying, basically. Okay. So if you ask them, right, a good example I will tell you, you ask them, what did they eat for breakfast? They will tell you what all they ate. Actually, they believe that's what they ate, but they don't eat anything, folks. So they are lying to you, but they think it's actually the truth. Does that make sense, folks? So they are lying that they don't even know they are lying. Okay. So this patient will say, I ate pancake, omelet, and all these things, but actually they didn't even eat anything. So they fully believe. That's confabulation, folks. Okay. Now, memory loss and confabulations are permanent damage. They ask you what part of the brain get affected to become a permanent loss. If you don't know this, this question is gone. It affects mammillary body. It affects mammillary body. So two type of question it comes. They put a picture of the scan and you have to identify where the mammillary body is, folks. When we do neurology, I will show you that structure, okay? Now, what exactly happening in mammillary body? It's actually mammillary body necrosis. Now that should tell you why it's irreversible, because once you have necrosis, can it go back to normal? No. Once it passes ischemia and infarction, it's done, isn't it, folks? So this is after infarction and necrosis, right? So mammillary body necrosis is a permanent damage. Once its death happens in the mammillary body, those cells are died completely, will never come back. Are we clear, folks? So you should know why Korasakov is irreversible. That's because you have a mammillary body necrosis. Clear, folks? Mammillary body plus hippocampus, right? I'm just mentioning these are two structures that's responsible for memory. Okay, whatever you study, if you want to remember lifelong, that has to go into the hippocampus. Is that clear, folks? Once it goes to hippocampus, that's where it becomes long-term memory, folks. The only way you could get whatever you study into the hippocampus, two things: repetition and sleep. Trust me, without doing those two, no matter how genius you have, no matter how much IQ you have, nothing happens. Okay, you need, because they say the memory processing happens on a REM sleep. We will talk about this in the neurology, right? Only on REM sleep you have the memory processing. That means you need to get enough REM sleep, and then you have to have enough repetition to cover that. Is everybody clear, folks? Yeah, that's a key. But mammillary body is the key structure that play a role in Korasakov. This will come in your examples. Okay, like at least I can recall 7 out of 10 students who take step 1, they tell they have this question. So they will, but if they ask you to pick an option, if you see mammillary body, that's much easier. But when they put that cross section or sagittal section of your MRI, kaput, if you don't know. That's how it is, okay? So we will see when you see some neurological picture on neurology. So that's Wernicke. Is everybody clear, folks? All right, so that kind of concludes the psychiatric disorders. Now we have pharmacology, folks, okay? Now, let's start the fun. Let's go here. Now, when it comes to pharmacology of psychiatry, there's a lot of psychotherapy, okay? Now, most of the psychotherapists, you just need to know what it is, basics, because these are done by psychologists, not psychiatrists, okay? So these psychiatrists are the one who does those therapies and stuff. But if you really see, folks, some of them like behavioral therapy, right? It teaches patient how to identify and change the behavior pattern, folks, okay? If they have an issue, for example, if somebody has a specific phobia, right? Let's say somebody is very scared to go on an elevator by themselves, right? So this therapist will take them and they will tell, how do you handle when you get to the elevator and stuff. It's all about conversation, okay? So that's behavioral therapy. Now there is something called cognitive behavioral therapy. It teaches patient to recognize and think process and what to do and how to adapt, all those skill folks, okay? And then we have dialectical behavioral therapy, designed for use in borderline personality disorder, but can be used in other psychiatric conditions. So you cannot memorize which therapy is good for which disease, because these therapy can be used in multiple psychiatric disorders, folks, okay? So most of the time, if you see one therapist, that they will go through all of them here, folks, okay? Now that's therapy. So I wouldn't really worry about therapies, folks. Let's start with first medication, central nervous system stimulants. This is what we just talked about, right? Methylphenidate, amphetamines, metham, all these things. It is such a highly restricted medication. If you don't have a diagnosis, prescription, or if your kids don't have a prescription and you carry one pill in your hand, cops will arrest you on the spot in state of Illinois. Okay, so even if your kid has ADHD and you are carrying, they handcuff you and they will call your daughter's or kid's doctor's office to confirm there's an active prescription. You cannot even have it in your hand, is because that's how much seriousness of this medicine, folks. So what does that do? This medication increases catecholamines in the synaptic cleft. We just talked about, especially norepinephrine. Why? Norepinephrine comes from dopamine. Does that make sense for us? So they increase norepinephrine. See, that's why we use it for ADHD, narcolepsy, and also binge eating disorder. Okay, binge eating disorder, folks. So these are that. Now, adverse effect. Think about it. If you increase sympathetic, what will be? All the sympathetic adverse effect, right? More sympathetic, that gives you nervousness, agitation, anxiety, insomnia, tachycardia. Isn't it looks like all sympathetic symptoms, folks? Look at that, even more hypertension. If they have to take it for a longer time to lose weight, but then they also, can this give chest pain? Technically, yes. If you take too much, it can give you chest pain. Okay. I actually have a student who's ADHD, and one of the days, the student took a little bit more dose, thinking that medication is not working. The student called me and said, my chest is hurting. The first question I asked, did you increase your dosage? The student was like, yes, I did a little bit. I said, you don't increase without talking to your doctor, because there's a way to increase. You can't just increase however you want. Does that make sense, folks? All right. So that's central nervous system stimulation. Is everybody clear with that? All right. Now, look at that, antipsychotics. Such a high yield topic for your exam. When I tell antipsychotics, what you think in your mind, these are dopamine blocker. These are dopamine blocker. We divide the dopamine blocker into two. Typical antipsychotics, atypical antipsychotics. two different ways, folks, okay? Typical and atypical. Okay. Now, if you see some example for typical, we call it first generation, haloperidol. As long as this comes to your mind, you are pretty good. So such a strong medication, haloperidol. That's the typical antipsychotics. When it comes to atypical, you have a lot of them, folks. You know, see, clozapine, olanzapine, quetiapine, risperidone, famous medication. Highlight clozapine. I'll tell you why there's a good side effect of that. So what is the difference between typical and atypical? Typical only works on the positive symptoms, which means it cures the positive symptom of schizophrenia, but the patient still will have the negative symptoms. Is everybody clear, folks? Whereas atypical, it works on positive and negative. So which one is better? Atypical is better, folks, because it cures both positive and negative. So which means it works on mesocortical and mesolimbic. Is everybody clear, folks? That could be a good question. Okay. So they could ask you where, instead of talking about positive and negative, they could ask you which pathway the medication works on. Okay. So that's your typical and atypical. Now you could see it blocked the dopamine receptor. Atypical antipsychotic also blocks serotonin receptor. So they have a little bit more effect on that. Okay. Now, to quickly talk about partial agonists, right? Now, partial agonists mean, like, put it in this way, folks, okay? Now, let's say full agonist, okay? So if I have a graph here, let's talk about that. Here is there. I am in pain. I'm giving a pain medication, so that makes it easier. If somebody is in pain, the minute I give full agonist, the medication will go 100% effect on the body. The pain will go away instantly. You won't even have a feeling that you had a pain before. It's like basically disappeared. Is that clear, folks? Now, when we say partial agonist, if I were to give a patient with the same pain, and if I were to give a partial agonist, the medication only works 50% in their body, which means half of the pain is gone, but you still have a little bit pain there left. It's not like completely disappeared. Is that clear, folks? Sometimes if you notice it, you have pain that really bothers you, that you cannot do anything. But sometimes you take a medication, you say, you know what, it's much better. I still have pain, but I can function. Is that clear, folks? That's what the partial agonist does. Partial agonist is basically takes a half of the effect, not the whole 100%. Now, this is why I picked the opioids. When people have a pain, we like to give partial agonist because partial agonist does not cause addiction. Okay, like if a patient comes, how many people have taken Vicodin in your life? It's okay, it's a pain medication. Anybody took Vicodin? What happens when you take Vicodin? You don't even remember having a pain after that, isn't it, folks? You feel like your leg is not touching the floor after that, right? Because why? Vicodin just makes you like you're a Superman after that, right? You don't feel nothing. But that's why when somebody take Vicodin for pain once, they would not take anything else, because they like that feeling of Vicodin. I always take tramadol. Tramadol is also pain medication, but it's a partial agonist. What does that mean? When I take the tramadol, my pain becomes much better. I can do everything what I want to, but I still feel the little bit of pain there. Does that make sense, folks? So tramadol, people don't get addicted. That's the whole point here, folks. Anytime you use partial agonist, the addiction is less. Is everybody clear, folks? All right. Same thing here, anytime you come across partial agonist. Anyway, so this typical and atypical works for schizophrenia. We could use, look at this, typical, primarily treat positive symptom, atypical works on both. We already talked about it, I mentioned it. You could use this medication for so many treatment, folks, okay? So many treatment. Now, when it comes to antipsychotics, you don't need to memorize in which disease you use. What you need to memorize, adverse effect. Look at that, how much it has. So much side effect. Let's start with this. First, antihistamine effect. When you take it, you feel sleepy, orthostatic hypotension, antimuscarinic activity, constipation, all those things. Okay. Now, why does it say use with caution in dementia? Because antimuscarinic has a short-term memory loss when you take it, same as Benadryl. So if you give this to people with dementia, it can make it a little worse of same memory loss. Is that clear, folks? Because remember, it's not one time, right? These antipsychotics are taken daily. So that's that. Next, metabolic effect. Weight gain, hyperglycemia, all those things. I'm not worried about that. This need to be highlighted, endocrine effect. When people take antipsychotics, why do they have hyperprolactinemia? Because they inhibit dopamine. When dopamine is inhibited, prolactin will be released automatically. Is that clear, folks? Okay. So that's one of the common problems when people take this medicine, they don't know, they feel galactoria. They see a little bit of galactoria, they come to the doctor's office. So if you see it, it's always the medication for galactoria. Okay. What's the biochemistry disease that we studied that's also increases prolactin, one of the deficiency in protein metabolism? What disease is that? In biochemistry, we studied that particular disease also has increased prolactin. So phenylketonuria, BH4 factor deficiency. Olivia just took a deep breath. That's exactly what it is. It's BH4. Increased BH4 factor deficiency also affects that dopamine, isn't it, folks? No dopamine, so increased prolactin. Remember that. All right. The next most important antipsychotics can prolong QT interval. So another medication. Prolonged QT interval can be supposed to develop toxins. Okay. For step one, I'm going to highlight this. This is the most important in this section. It causes neuroleptic malignant syndrome. We're going to talk about that in a moment. What is neuroleptic malignant? Next thing you should know, clozapine causes agranulocytosis. What does agranulocytosis mean? Decreased WBC. So you prescribe somebody clozapine, they will come back after a couple of weeks complaining of sore throat and fever. What does that mean? Because it causes decrease in WBC, no innate immunity, and you have infection in your body. Is that clear, folks? So when you prescribe clozapine, CBC must be done very, very quickly. Is that clear, folks? Tell me one more medication we studied so far that also causes agranulocytosis. That they come up with fever and sore throat. I mentioned this. I'll give you here endocrine. Endocrine.
Wait, what's the question again?
Other medications that causes agranulocytosis. PTU and methimazole. Okay. Now, PTU and methimazole also does the same thing, folks. Okay. It causes that. Okay. Now, agranulocytosis, right? Clozapine. I missed this question in my medical exam 10, 11 years ago. I still remember that. The reason is we always remember the mistakes we make. Okay, that's not what it is. So in my exam, this is how they had options for that. They had A, B, C, whatever option. A, they had granulocytosis. Right? What is granulocytosis? That's actually increased WBC. Is that clear, folks? I read the question too fast. And again, I know this. I practice this. Because I read it as agranulocytosis quickly when you see that. You know, they are all wrong with that. It bothers me so much after because that's an easy question. You would have like three points for that. Right? So it's actually not. It's grammar exercises mean increase. I just read it together. Does that make sense, folks? So pay attention to your read options. Okay. Very that like case my mistakes on spelling exam is because we read fast. I'm not going to make mistakes. So careful. Yeah. So that's that exam was now this is kind of important here. Extra-pyramidal symptoms. Okay. Extra-pyramidal symptoms one side like these people take long-term antipsychotics. Okay. Now, when you see long-term antipsychotics, right? Exam has what happened, hours, days. They have this muscle and all these things. They don't ask you about days, month. What are those effects? Look at the word. Yeah, I'm going to go about the Parkinson's. You give antipsychotics, but I'm talking dopamine. When there is no dopamine disease, Parkinson's is an folks. So we call this drug-induced Parkinson's, right? So the term Parkinsonism. When you see the word Parkinsonism, the main issue is not medication induced. Exactly, folks. We don't use the word drug-induced Parkinson's disease. We call it Parkinsonian effect. If I have a patient with Parkinsonian effect, which means the patient must take medication that gives that effect. Exactly, folks. So that's Parkinson's. Just to remember, they don't ask that either. This is what they ask you. What is it? Tardive dyskinesia, folks. Okay. Now, this symptom happens only 1 to 2 years after using. They slowly develop. The minute you see that symptom, we stop that medication permanently. Because if they develop this medical condition, the tardive dyskinesia is permanent and never goes back. Okay. What is that symptom? It's an overall facial symptoms. I'm not trying to make fun of a dog. Have you guys seen dogs that look around the mouth? That's exactly what they do. These humans will do all their reactions. They sit in a place wherever they are. They keep doing those facial movement, folks. Okay. If you YouTube, there's a lot of videos. That's called tardive dyskinesia. Once they have developed that symptom, it will never go away. So the minute we see a patient that they are possibly seeing, we stop them. Okay. That's tardive dyskinesia. Such a danger symptoms or facial. Now the treatment, benzodiazepine, we could do all these things, but it's kind of symptom controlling, but you cannot cure it. Is that clear, folks? So that's that. So they definitely check that on the exam if they have. So that's antipsychotics. Most of our part. Now let's see here. Some notes are here for this medicine. Look, when we talk about the first day, we said when it comes to medication, there's lipid soluble or water soluble. Lipid soluble means they stored in the body fat more, and it's slow to be removed from the body because the fat cell will release slowly and stuff. So technically, lipid soluble medication stays in your body longer than water soluble. Is everybody clear, folks? So the more it stays, the more side effects also. Okay. Now you can see here. There's a type of medication, high potency antipsychotics. Those are these. Okay. The higher the potency means, the higher the side effect. Low potencies are the other medications, their side effects are less. So high potency means think it's very strong medication. Is that clear, folks? So that's the key. Okay. Higher the potency, the more stronger, folks. Okay. So that's pretty much. Now, what we need to learn. What is this neuroleptic malignancy? Okay, that's a must. It comes on the exam. We need to go a few pages back. On top of the delirium tremens, you will see this neuroleptic malignant syndrome. Now, when you see this neuroleptic malignant syndrome, you see it says antipsychotics, typical, more than atypical, and all these things. That's not important for us. How do we pick up what are the symptoms? When people have neuroleptic malignant syndrome, neuroleptic malignant, and also known as hyperthermia, which means they have to have a fever. They have such a high fever and muscle rigidity. So when people take this, folks, I actually see people in the hospital. So let's say they take for a few weeks to months this medication, they wake up, they cannot even turn the head like this. The muscle is fully rigid. They're like a dog sitting in one position, okay? They cannot turn because all the muscles are fully rigid. They have high fever. And then what happens when the muscles are rigid? They try to break down. That causes myoglobinuria. Is that clear, folks? That's it. You cannot. And then these patients are psychiatric patients. The minute you wean them off, they will do things that you cannot handle. That's the other part. Remember, these are extreme psychiatric people, folks. Okay. So that encephalopathy and vitals, those are different. But I think let's highlight the most important ones. Fever, myoglobinuria, muscle rigidity. That's all it is. Okay. That's all it is. When people take antipsychotics for a long time, it's dopamine antagonist. Some places they give a higher dose to control the patient because some patients are very aggressive. Now, if you see these psychiatric people, right, they are like 1 human is equal to 5 humans. That's what energy they have. That's a reality. You can't control it easily. So they give them higher dose of that. One of the patients I met, they brought them in. It's not because of this. Small bowel obstruction, 100%. So we got to do a laparotomy and remove a portion of intestine, because the reason when they take this medicine for a longer time, we see an associated symptom of bowel necrosis. The bowel is not moving after that. Okay. Now we don't know how to explain direct link, but it's happening, something to do with the dopamine blocking. Is everybody clear, folks? Okay. So that's one of the key, and that's where I actually saw a patient and I tried to take a high and they talk, but they cannot turn the head. It's that much muscle rigidity, folks. Okay. So that's neuroleptic malignant syndrome. You should know the drug of choice, dantrolone. Okay. We have to give that medication first. And then of course we have to discontinue antipsychotics. The minute they discontinue, or after a few days, they will pull their urine catheter, everything. You cannot control them. Oh, it's their energy. That's a problem. So, okay. So this guy pulled the whole urine catheter without deflating. That's painful. I don't know how they did. Oh, they do. They do. Okay. So that's neuroleptic malignant syndrome, folks. Okay. Let's go back. So that concludes what is neuroleptic malignant syndrome and all the side effects. If you know this much, you're not going to miss anything in antipsychotics. Are we clear, folks? All right. Let's go to next one. Lithium.
Sorry, quick question. You said it was the anti-muscarinic aspect that causes the memory loss?
Yes. Same thing with your Benadryl. It also has a little bit of anti-muscarinic activity, like 5% of what these guys are capable of, antipsychotics. Okay. Now, lithium. A lot of the time, we don't know how lithium works, but you should know lithium is a mood stabilizer, folks. Okay. It's mood stabilizer. Now, we already know the minute we say lithium, you're going to say a few diseases, folks. Okay. One is nephrogenic diabetes insipidus. Next, Epstein anomaly. What type of valve problem do you have in Epstein anomaly? Type it up. I want what type of valve problem. Be precise. I didn't ask what valve. I know the name of the valve, but what type of problem in the valve? Is it stenosis? Is it regurgitation, or what it is? You see, you guys know the name of the valve, but kind of hard to remember what problem in that valve, right? It's a tricuspid regurgitation. Why? Because the atria is going down, right? That's the idea. All right. Atrialization of the right ventricle. Remember that word? Okay. That's Epstein anomaly. Epstein anomaly, nephrogenic diabetes insipidus, folks. You cannot forget. It is a narrow therapeutic agent, which means giving a little bit more than usual dose will give you toxic effect. Exclusively excreted by kidney. Most is reabsorbed in PCT. Look at that. So now you know why it's a problematic medication. Even though they are filtering 100%, some of them are reabsorbed back again. Is that clear, folks? So that's why lithium is a very carefully monitored, folks. Okay, that's that. If you remember these two side effects, you won't have any problem with lithium, folks. Okay. Now, next, buspirone. We just talked about it. It is the drug of choice, not for that generalized anxiety disorder, not bupropion. Okay, I was thinking bupropion. Buspirone is one medication. Write it down. Bupropion. There's another medication with a similar word. We use that for smoking cessation. That's a drug of choice nowadays for the step 1. Okay, bupropion, buspirone. You see, you get confused between these two, so you have to be careful, folks. What is generalized anxiety disorder? You have to be more than one worry, right? Multiple worries. What's the timeline? How the timeline for generalized anxiety disorder? More than how many days, weeks, months? More than 6 months. Very good. What do we call it if it is less than 6 months? What's the name of the disease? The same generalized anxiety disorder, but it's less than 6 months. Come on, folks. I only see one answer. Do you guys have a memory loss or dementia? Put a fire next to you, so let me see if you can think. It's adjustment disorder. Come on. The same thing. Adjustment disorder, more than 6 months, we call it generalized anxiety disorder, right? All right. So buspirone is that. It doesn't cause sedation, addiction, or tolerance, okay? But when you take the medication, it takes 1 to 2 weeks. See, the way to think of addiction, whatever gives you very sudden change causes addiction. That's how you want to think, which means any medication that works quickly. See, it's all about how different you feel it, folks, okay? Now, I was telling them, right, when you are in extreme pain and you take Vicodin, the pain goes away 200%. So you feel good instantly. People like that change. Then you become addicted to Vicodin. Does that make sense, folks? You always want that. But when you take a medication that takes long time to work and the effect is not really seen quickly, you see it slowly, people don't get addicted to that. Does that make sense, folks? Because we don't see the quick change. Same thing here. Buspirone takes 1 to 2 weeks to get the effect. So you don't even feel when the medication is working on your body. So you never become addicted to that. Is that clear, folks? That's the idea. Okay, that is the idea. Now, doesn't interact with alcohol. Okay, that's fine. So that's buspirone, folks. Now, next, we're going to talk about antidepressants medication. Now, when it comes to antidepressants, right? What hormones you guys know that's responsible for happiness? What makes you happy? Serotonin, isn't it, folks? Okay, so most of the time, you need to understand the basic problem. When people are sad, what is down? Serotonin is down. Is that clear? So your objective to treat a patient for depression or anything is to bring the serotonin higher. So if you see, it says selective serotonin reuptake inhibitor. So they inhibit the serotonin reuptake. By doing that, they are increasing the availability of serotonin. Okay, availability of serotonin. Is everybody clear, folks? More serotonin you have, more happier you are. Or you could take more tryptophan, because tryptophan also gives you serotonin, isn't it, folks? All right. Fluoxetine is a very famous medication. Citalopram, also taken paroxetine, all of them, folks. These are very famous, okay? We could use it for depression, even though it says CGD, you know, there's a multiple diseases that you could use as. I wouldn't really pay attention to clinical use, but I would pay attention to mechanism and adverse effect. Because you see, it can use for freaking all the psychiatric diseases, basically, right? So remember that. Now, fewer than the other TCAs, serotonin syndrome, GI distress, some SAIDH, sexual dysfunctions. Those are all can be an adverse effect. One of the famous questions used to be on NBME. Patient is given fluoxetine and the patient comes back after a week or two and complains that patient has not felt any different and it's the same effect. What is the next best step? Most of the students click switch to a different medication. That is a wrong answer. It takes about 4 to 8 weeks to see the effect. So what do you tell the patient? Reassurance and send them back. Okay, unless they take it for 2 months, you cannot see it, folks. You see, they don't see the sudden difference. No, it takes so much time. Okay, even the funny part is after 2 months, if you ask them, is the medication working? They were like, here and there, because they don't even feel that it's working. You know, when they hit them, if you stop them right after that, they will be like, no, it feels weird. See, the problem is when people take antidepressant, it's not that they like it when they take it. Only problem is when you stop, they see the difference. Does that make sense, folks? That's why when people start antidepressants, they go years and years, folks, okay? So that's that. So that's the first one. Now look at the next.
Is fluoxetine the same as Prozac, right?
Yeah. So next, serotonin, norepinephrine reuptake inhibitor. Look at that. This is doing both. So what are the two things increase in the cleft now? More serotonin and more norepinephrine. So if you have more norepinephrine, you should expect all the sympathetic effect. Is that clear, folks? Now look at this. We could use it for depression. We could use it for depression, but the side effect, look at that, increased blood pressure. Why increased blood pressure? Because it's norepinephrine works on alpha-1 receptors. Now, would this be a drug of choice if a patient has hypertension? No, you cannot, because it will cause more damage, okay? Stimulant effect, sedation, and all these things, but the only difference, they are both 5-HT and norepinephrine. Is everybody clear, folks? Now, if you see the big picture, all the antidepressant medication, it doesn't matter what group it is. They have to work on the either serotonin or norepinephrine, nothing else, folks, okay? Now look at the third one now. Tricyclic antidepressant. They inhibit 5-HT and norepinephrine uptake. That's all it is, folks, okay? Now, medication. Amitriptyline is very famous. This is, where did we come across? Type it up. Where did you come across this medication as a treatment? I asked you guys to highlight this. Imipramine. Where did we come across? At that time, I said, this is the second line or second drug, not the first. This is a second because it has a side effect. If I tell the first drug, you guys know the name of the disease, so I cannot tell the first drug. First drug is desmopressin. Okay. Which one is it now? It's the enuresis bedwetting. Is that clear, folks? When people have enuresis, we give desmopressin first and then imipramine. When do we say it's abnormal to have enuresis? What's the age limit or cutoff limit? When do we call it normal? 5 years, right? 5 is the limit. Before 5, reassurance. After 5, desmopressin over imipramine. Is that clear, folks? All right. Now, why did we say desmopressin is the first one and imipramine? We're going to see it now because it has a lot of side effect. Look at that. That's a lot of side effect even by looking at it. Now, if you see here, we could use it for major depression. And you guys had it here. You guys are too naive, didn't even look at it. Okay. So that's there. Now, it causes sedation, alpha-1 blocking effect, including postural hypertension, atropine-like effect, all these things, the urinary retention, dry mouth, all these things, anticholinergic effect, highlight QT prolongation. That's important, folks. These are cardiac complications. It can give convulsions, coma, cardiotoxicity. Respiratory depression, look at that. You don't want to give a medication causes respiratory depression to a bedwetting. Okay, so that confusion, hallucination, all of these can do that, folks. The treatment or overdose treatment is sodium bicarbonate that you can prevent arrhythmias with. That's tricyclic antidepressant. Is that clear, folks? That's that. Now, the next type of antidepressants, monoamine oxidase inhibitor, MAO, okay? These are non-selective MAO inhibitions, which increases amine neurotransmitters, which is your norepinephrine, serotonin, dopamine. You see that? It's the same thing, folks. Serotonin, norepinephrine. The only additional thing here is dopamine, but we should know dopamine gives rise to epinephrine and norepinephrine. Does that make sense, folks? Okay. So the same thing, we use it for atypical depression. What did we say atypical depression means? These are the abnormal symptoms. Sleeping a lot, eating a lot. Remember that? Those are the ones, folks, okay? Now, it's a CNS stimulant. It can give you hypertensive crisis, especially if they take the medication while they're ingesting tyramine, right? Tyramine is a substance found in the red wine, cheese, and all these things. So they cannot take this medicine and eat those substances. Their blood pressure will go up. They always ask you why. The answer is hypertensive crisis. Make sure you know that. Hypertensive crisis, okay. Contraindicated with other medications, folks. And they ask you, how long do they have to wait? It's 2 weeks after you stopping. You need to wait 2 weeks after stopping the inhibitors before starting other serotonergic drugs or the restriction, folks, okay? So that's MAO inhibitors. Now, going here, these are atypical antidepressants, folks. Atypical, right? Now, this is considered low yield, but if you look at it, all of them work in the same thing, folks. Inhibit norepinephrine, dopamine reuptake, blocks 5-HT, inhibit 5-HT. You see, if it is a depression, antidepressant, it has to work on serotonin and norepinephrine. Okay, so that's that. Look at the word bupropion, highlight that. I mentioned that, right? Buspirone is for CGA, what is it? Generalized anxiety disorder. Bupropion is for smoking cessation. It's a boat favorite, folks. This one is a boat favorite. Okay. Next one I will tell, trazodone. The only thing you want to remember, this is the only medication that we call it medication-induced priapism. Okay. So when we say medication-induced priapism, you think of trazodone, folks. Okay. Other than that, you could read the rest. I wouldn't worry about it. Let's go here, super high yield. This is where we're going to worry about the opioid effect, folks, okay? Now, when it comes to opioid detoxification, these are pain medication injection. Injection drug use increase the risk for the infections. You should know that. And we also said right-sided heart valve disease more common than left side because IV drug abusers mean more chance for the right side. Okay. Now, the way you want to think, when people come with opioids, right? Let's think about it. Let's say a patient comes with opioid overdose. That means they are taking a higher dose. What is the first thing we do? We're going to give naloxone. So I'm just going to put number one first, okay? We're going to give naloxone. These are short-acting opioid antagonists given intramuscular, IV, or nasal spray to treat acute opioid overdose. So you have to first treat them overdose before you send them to rehab. Does that make sense, folks? Particularly to reverse respiratory and CNS depression. So we give that medicine. Then we go for naltrexone, which is a long-acting oral opioid antagonist used after detoxification to prevent relapse. So you have to give that. May help alcohol and nicotine cessation, weight loss, and stuff. Sometimes we also put methadone. I'm going to put number 2 on that too. It's also long-acting oral opioid used for heroin detoxification or long-term maintenance, folks, okay? But the bottom line is before you go for maintenance or prevent relapse, you need to treat acute condition. Is everybody clear, folks? So definitely this will be your number one choice always, no matter what, because you need to treat the overdose, folks. Then we have another one, buprenorphine. It's a partial opioid agonist. Look at the word partial. So when they take it, they will never feel the addicted effect on that, folks. Okay, it's a sublingual form used to suppress withdrawal for maintenance. That's the idea. Partial agonist only side effects can precipitate withdrawal symptom in opioid dependent individual because they are used to taking such a high dose. Now they are taking partial, folks. Okay, and that's that. Now that's opioid detoxification. You know, that's a rehab and stuff, folks. All right, well, that concludes the farm. If you see antidepressant, simple, right? It's serotonin, norepinephrine. Always keep the strategy of it. Take a break and come back.